My first case I'm Jeremy Wolfe, so my first case is very similar to Dr. Yonakawa's, so we'll go and then we can discuss a little more. But here you can see probably the lens is dislocated, and we're placing the trocars there. The 27 gauge were 180 degrees apart, just like Dr. Yonakawa, but I did additionally add a 25 gauge normal 3-port vitrectomy. And that was because I was concerned with the Sommering's ring, whether or not I would be able to adequately dissect it with the 27 gauge. As you can see, there's some pretty significant cataract capsule left there. So, and in this case, actually, I did put a chandelier in so that I could have bimanual. I could hold the lens in the posterior cavity and use the cutter at the same time. Following the same process, Dr. Yonakawa just showed us externalizing the inferior haptic here, and that happens very nicely. And then go back to the vitreous cavity to grab the superior haptic, and upon doing that, you see that refractive body there, reflective body, which is actually the tip of the forceps. And so then, in addition to having a dislocated lens, we had an intraocular foreign body. Fortunately, that was a 27 gauge max grip forceps, so it's very, very small. And what we're doing here, and we already had a chandelier, so what we're doing here is taking another forceps and basically forcing that broken end into the cutter, the mouth of the cutter, and then we removed the cannula and it slid right out. So it actually turned out to be rather smooth, although I can say when it occurred, I was somewhat surprised. And then the rest of the case proceeded as we would expect. I fixated the lens before removing the rest of the retained lens material to avoid the lens whipping around inside the eye. And there at the end of the case, the lens is fixated quite nicely. I'm curious, in the United States, we do not have artisan lens, which I know is very popular for secondary IOLs here. So we have this technique, which we do like in the United States. Akito, in Japan, what do you do for secondary IOLs?
Just like Dr. Yonakawa said, Yamane technique, that is very useful to use a 30 gauge cannula to inside to hold the haptics. That is very useful.
So very similar, but you use the double needle technique instead of a cannula.
That's right.
Yeah. OG?
I do something similar, but I still use the 23 gauge to do my own technique. And in some older patients, we still use the ACIOLs when we have dislocated lens. We get the lens out and put it inside the ear. So, but for the younger patients, we do this, but I use the 23 gauge.
23 gauge.
Yes.
And then do you?
And I talk the haptic into the sclera.
You cut down and put it underneath a scleral flap.
Yes.
Yes, and so I think it's very attractive for putting the lens into the posterior chamber, which for a younger patient is, I think, important. My next case is keeping with the theme of our conference here, and it's not completely obvious why at the beginning. So this is a normal retained lens. The patient had cataract surgery with an anterior segment surgeon and was sent in with a ruptured capsule and retained lens, and was scheduled for surgery, vitrectomy, and lensectomy the following week. And here at the time of surgery, it looks like there's a fibrinous reaction in the anterior chamber, and upon removing the anterior material, the posterior view reveals diffuse retinal hemorrhages, which were not noted at the initial exam. And so we're very concerned that the patient now had endophthalmitis in addition to their retained lens material. So we placed intravitreal antibiotics at the completion of the case. Indeed, the culture was positive for coagulase negative staph. The vision had improved, but in a postoperative exam, it was noted that the anterior chamber was very shallow with extensive pigment dispersion. Here's a UBM picture of the lens in this patient. Dr. Osdek, what do you think happened here?
I think the IOL is just reverse. I mean, the angle is just reverse, so pupillary block.
Yes, and so it's very exactly right. So there we're just going in and going to just flip the IOL, and so indeed the anterior segment surgeon had, I'm sure, was under a lot of stress, and the lens was upside down. And in the first surgery, I was not able to notice that. So we just went back and flipped the lens over and put it back. Fortunately, the capsular support was very good, and we just put it back and left it in place there. And afterwards, she has done very well.
That's a nice flip.
A nice flip, thank you. And so, the interesting thing for me is that the next week I had the exact same occurrence. I had a retained lens material patient who I then scheduled for surgery the following week, and again, they came in with endophthalmitis. So in a matter of 2 weeks, I had this happen twice, although I have never previously seen it. Has anyone on the panel encountered this phenomenon? No. Yeah, so lightning struck twice. But fortunately, they both did very, very well.